Recently, the Society for Vascular Surgery decided to put together a video archive cataloging many of the leaders and innovators in vascular surgery so that younger people could better understand the development of our specialty. And today we have Greg Sicard, who has spent almost all of his professional career at Washington University with us. Welcome.
Thank you. Thank you very much.
So you were born and raised in Puerto Rico.
That's correct. I was born in Ponce, Puerto Rico. Ponce is the second largest city in Puerto Rico, but I was actually raised in a town east of Ponce called Guayama, which was a sugarcane mill town, had 4 sugarcane mills. So I grew up in that environment.
And then you're from a medical family.
That is correct. My father is a surgeon, was a surgeon, and my mother was a nurse.
Oh yeah. Was he a general surgeon?
He was a general surgeon in the era of the true general surgeon. He did orthopedics, GYN, and always said he didn't do neurosurgery because they kept him away from the drill. But otherwise, he did all types of surgery.
Did you end up in the operating room with him when you were younger? Did that lead you toward going into surgery, or?
At 5 years of age, after getting good grades in first grade, I ran home to show my mom and dad, and my dad was operating, so my mom told me to go to the hospital. And that's a picture that you never forget. That's ingrained in your mind. It was a ventral hernia that he was repairing. It looked like it was the ventral hernia in King Kong. It was probably a small lady, but to me it looked like it was a giant ventral hernia, and that was my first exposure, because when I got to the operating room, my dad just told him to put a gown and a cap and gown on it and to bring me into the operating room. So I did, and I found it interesting, exciting, and was not shocked by what I saw.
And then you ended up going to college in St. Louis. How did all that transpire?
Yes. A good friend of my father, who was a physician, who was my baptismal grandfather, he lived in Ponce and had 2 sons, had a large family, but 2 of the sons went to a Marianist school, high school in Ponce. He wanted his children to end up in the United States for college, and when his oldest son graduated, the Marianists there suggested St. Louis University.
Right.
His youngest son came to Chaminade, which is a high school in St. Louis, and when my dad thought that would be a great idea to have both me and my brother educated in the United States, that was the point of that we knew about, or that my dad was able to get a lot of information. So we came to St. Louis in May of 1960.
Oh yeah. And then you ended up going back to San Juan to medical school.
So I did my last year of high school in St. Louis, because my dad wanted me to get a little bit more fluent in English, and went to St. Louis University, and then finished medical school in the University of Puerto Rico. That's correct, in 1972.
And then did you decide during medical school how did you decide that surgery was it, or had you known ever since you were 5 years old?
Since I was a young kid, and I had other older cousins that became surgeons, and with my father being a surgeon, and his mentor, which was actually an adopted man that was raised in the same house as my dad was raised, that eventually went to Europe, to France, and became a physician, a surgeon in France. He came back to the Dominican Republic, where my father was from. So we had that sort of ingrained into our system. We were, always heard about surgery, grew up around surgery, and so that was there was no question in my mind that was my calling also.
Yeah, and then I guess St. Louis was the obvious place to look for a residency, since you knew it well.
Well, there's always a woman involved in all those decisions. So in the last year of college at St. Louis University. I met my wife, and actually in the third year, I met my wife, and then we got married in my fourth year, and have been happily married for 48 years. So she was from St. Louis, only child, so she wanted to get back there, and it was an easy and very nice decision that I've never regretted it. The other point was that in medical school, one of my professors, Jose Asensio, was the chief of surgery at the VA hospital, was a very close personal friend. They trained together in Philadelphia to Walter Ballinger, who was the chief of surgery at Barnes. So again, that was became, everything started falling together with my wife being from St. Louis, me having been in St. Louis to do my last year in high school and college. So that's where I only matched two places in my match, and in those days that you could do things like that. And
Yeah.
I came up as a senior medical student to Barnes, and basically I was told by one of my mentors, Dr. Butcher, that if I put him first in the match, that I would get in, and I did.
Oh, that's, yeah. And then tell us about who your mentors were in your residency back then. You mentioned a few.
I think I had the fortune and pleasure and privilege of working with real giants in surgery, guys like Harvey Butcher, Jim Bricker. These were men that really made important contributions to American surgery. Walter Ballinger, once I finished my residency, he stepped down from the Department of Surgery. But Harvey Butcher continued working. He was a gifted surgeon, just like Dr. Eugene Bricker was. And then I had the great pleasure of working with Charlie Anderson, who had started the kidney transplantation at Barnes Hospital. And that caught my eye, caught my attention, and he gave me the opportunity of doing both vascular and something unique and new, that was fairly new at that time, renal transplantation.
And so then you actually did a formal fellowship in renal transplantation in 1977.
Yeah, as you know, at that time there were no vascular fellowship. Northwestern had one of the leading vascular fellowship, but there wasn't an ACGME recognized fellowship. The American Society of Transplantation had formed a fellowship that they accredited, not as an ACGME accredited program, but as part of the societies, like still a lot of societies have that. And it gave me a unique opportunity, because at that time there was a void for vascular surgery at an institution. So I was able to do vascular surgery, transplantation, and also general surgery. So it was a unique opportunity to do all three. So I became the first fellow that Barnes ever had in any area in transplantation. Yeah.
And then who taught you the details of vascular surgery in your own mind? Who were the people that were doing the aortas and doing carotids and so forth that you learned from?
There were a lot of excellent general surgeons, private practitioners that practiced at Barnes that really taught me a lot. But I think the person that I learned the most from as a resident vascular surgery, the two people that I learned the most was from Harvey Butcher, who trained a whole generation of great general and vascular surgeons, as well as Charlie Anderson, also was an excellent technical surgeon and a leader and a great mentor. So, but the vascular surgery, I think Harvey Butcher was the person that caught my eye as a great, with his technical skills and his dedication to teaching vascular surgery, and also recommended that vascular surgery would become its own field.
So then you ended up, I mean, finally you ended up being the chief of vascular surgery and the chief of general surgery at WashU, and also we're doing kidney transplants.
Yes.
So it's a busy, complicated practice.
It is. It was a busy, complicated practice. When Dr. Ballinger stepped down, some of the young surgeons that had been recruited left the institution, so there was a huge void. So basically, there were 5 surgeons in the Department of Surgery. Now we're 70 something. Well, the department has 140 now, but general surgery in those days only had 5, and now we have 50 or 60. Mm-hmm. So it tells you an idea that there was a huge need and an eager team of young surgeons like Charlie Anderson and myself, that we were willing to work 36 hours a day and mm-hmm. and just did it. And so because of my interest in vascular and Charlie's interest in transplant, he was the head of transplantation. I was actually one of the private surgeons that had a very busy practice that recommended to Sam Wells, who had just become chief, mm-hmm. To make me the chief of this new upcoming vascular residency training. That was right around the time that they were talking about the ACGME approving the vascular residencies, and Dr. Wells agreed to it, and I was willing to do it.
So at a point there, you were doing laparotomies for general surgery and kidney transplants and aortic aneurysms and carotids and so forth in your practice.
Yeah, I was doing close to 1,200 cases a year.
Oh yeah.
So it was a very busy practice, but the way we compartmentalized that was in a unique fashion. So there were 3 transplant surgeons. We would take transplant 1 out of 3 months.
Okay.
And for 30 days or the month, we would you take care of the transplant program. Mm-hmm. And the transplant program included vascular access, parathyroids that were allowed being done. In those days, because we only had Imuran and prednisone, but to increase the effect of Imuran, a lot of splenectomies.
Oh yeah.
So all the patients had splenectomies. And we were doing a lot of nephrectomies for hypertension because there weren't as many antihypertensive agents. Mm-hmm. So during that month that you were on, which was every 3 months, basically you did between 100 and 150 cases, most of them very good cases. You did not do general surgery,
yeah.
or vascular surgery, mm-hmm. unless it was to a transplant patient. Mm-hmm. Okay, so that was your month. And so then in the other 2 months, we was basically 50-50 general surgery and vascular surgery. Mm-hmm. And we were able to do that when I first took over the transplant program, or organized it as a service in 1983. I think the total number of cases done that year was like 385, and now procedures we're close to 4,500 to 5,000. So it was in the era where vascular surgery was starting to take off, and as that grew, then it became evident to me that I had to get rid of something, and I didn't want to get rid of general surgery, so I decided to stop doing transplants. Charlie continued to do transplant and did very, very little vascular surgery. So I was able to concentrate more in vascular surgery, but still doing some general surgery as we build the department, or Sam Wells built the department. And then hepatobiliary surgeons came in, minimally invasive surgery started growing, et cetera, et cetera. So that allowed me to then gently sort of back off from the general surgery and dedicate to vascular.
So once you took over the vascular surgery, the program really has become very large at WashU, and you've had the opportunity to work with many talented surgeons. Tell us about some of those that are vascular surgeons.
Yes, well, I think that we went in, our fellowship, and I don't know exactly why, maybe it was because of the uniqueness of our institution with very little competition in the city and a large institution, many beds, many patients, that it attracted outstanding fellows mm-hmm. right off the bat. And that's a unique and great position to be in, because you can then, as you're growing, you can select your partners by mm-hmm. people that have worked with you. And that's what we did. But we also did not want to make it an ingrained type of group. So I did set out to recruit people from the outside, like Rob Thompson, that had finished the Mass General and had done in general surgery, and then did a fellowship with Ron Stoney in San Francisco. And I was lucky enough to bring him back to the Midwest.
And he's done a lot of important research and worked on various clinical things too.
Yeah, he decided he wanted to do he wanted to be a clinician scientist, and we provided him with all the facilities to do that, and has been very, very successful at that. As the endovascular techniques grew, and for other reasons that I'll mention a little later, when we talk about Juan Perotti, I felt that we needed to enhance our endovascular thing, and Luis Sanchez came to give a talk to the San Luis Vascular Society. So I had the opportunity to talk to him and chat with him, and was able to recruit him to San Luis, and now he's the chief of vascular surgery.
Oh yeah. And Brian Rubin has worked with you for a long time.
Brian trained with us. He was one of those very bright, talented individuals that I was afraid he was going to want to go back to the East Coast. But his wife was from the Atlanta area, wanted to stay a little bit closer to the Midwest, so that worked out great. So I think, I've been fortunate, our group has been very fortunate that things have fallen into place, and that very few of our people that we've kept have left. They've stayed there, they like the environment, and then been able to grow academically, and they're very happy there.
And then a few years ago, you were able to attract Juan Perotti to come and be with you.
Yeah, that's an interesting story. I had met Juan when he was a resident at the Cleveland Clinic because of our Hispanic background. But what really joined us together was that there is a society that I was part of it that was called Spanish-Speaking Vascular Surgeons. That started in Barcelona in 1988, and very prominent surgeons from all Spanish-speaking countries and the United States. Ramon Berger, for example, was president of that society. Also, Ed Bevan, who was chief of vascular at the Cleveland Clinic, was president of that society. So we had very, very good, thoughtful people that have made important contributions to vascular surgery. The first meeting was in Barcelona in 1988. The second meeting was in Argentina. Juan knew that I was going to the meeting, and he called me. And the meeting is always around Columbus Day, which is the 12th of October. So the scientific meeting was 11th and 13th, and the 12th is sort of a party day for the local folkloric type of party that it would be given depending on which country you were in. Anyway, he called me and he said, when you come, could you bring a CD to the hotel so that I can show you something? So he brought a CD of the first two endovascular cases he had done. He had done them in September of 1990. This was in October of the 1990. So when I saw that, I was impressed, and I said, Juan, I really think you have something here. So that established
it was surprising, wasn't
a very close bond, because he wanted to hear from people, is this a crazy idea or not? We saw each other in a few meetings, and I kept telling him, I said, you got to keep going with this. But then something that will surprise you and will bring a smile to your face is that probably one of the main people really that has something to do with Juan's success and also to our friendship was John Bergen. John was invited to a meeting that Louis Corral, another graduate from your program here in Northwestern, used to have a meeting right before the SVS in Miami for the Hispanic-speaking people.
Yeah.
And it was a vascular meeting, and he would invite surgeons to talk about vascular surgery.
And John Bergen speaks Spanish.
And John Bergen speaks Spanish, but he was giving, everybody gave their lectures in English, but they had simultaneous translation.
Yeah.
Anyway, Juan was there, John was there, and we had the meeting, and the second night of the meeting, Louis Corral gave a dinner at the Versailles. It's a well-known Cuban restaurant in Calle Ocho in Miami. And we were sitting, and John Bergen was sitting to my left, and Juan Perotti was sitting right in front, and Ramon Berger was right at the end of the table. So Juan tells me in Spanish, he said, you won't believe it, I sent an abstract to the SVS, to this SVS that's coming up on my first 8 cases, and they turned it down.
Yeah, I remember.
So I said, you gotta be kidding me. He said, no, So I turned over to John Bergen and I said, John, listen to this story about Juan. And John said, no, that can't be. He said, you got to publish that now. And we both looked at Ramon Berger, who was at the end of the table, and we waved them over and I said, you got to listen to this story. And Ramon said, no, you got to send that right away to my journal. And he was published in the Annals of Vascular Surgery, in '91. So that's how that whole, thing came out about, to solidify our friendship. We stayed in touch, and then we had a meeting at the UCSF that he was invited and I was invited, and he was unhappy with the political and safety environment of Argentina and brought that up to my attention. At that point, I wanted to start a carotid stent program because it was hard to get training in carotid stenting, even though we had endovascular training and we knew how to do it. It was hard to get some of the cardiologists that were nationally recognized that were doing it interested in training vascular surgeons. But Juan had been doing carotid stents in Argentina, so I saw the possibility of really doing something unique and not only help us build a program, but also, Juan is a privileged mind and I had a lot of ideas in vascular surgery, so I thought, this may be the place to come. So we discussed that, and then Juan and his entire family moved to San Luis for a little bit over 3 years, then he returned back to Buenos Aires.
And you worked on the retrograde flow mechanism for doing carotid stenting at that time.
Correct. He had developed that concept of retrograde flow, so we not only was he able to prove that this was a good technique using the retrograde flow, but also gave us an opportunity to learn how to do carotid stents. So our whole team was trained basically in carotid stenting and this new way of doing it.
One of the things that I remember about the beginning of the endovascular treatment of aneurysms was how you allowed the community surgeons to send cases and bring cases to WashU so that you could do a lot of those cases early on and publish important things on them.
Yes, the San Luis Vascular Society, when we formed it, we tried to form a cohesive group of camaraderie. And then when the endovascular thing came up, and we were doing some of the early clinical trials, the community vascular surgeons felt that they were being left out of this and they weren't sure where to turn. So I used that as an opportunity to establish, we were already friends, but to establish a trust. In our environment, it's very common to feel like if I send a patient or I get a second opinion, they're going to steal my patient. And that wasn't the intent. So I met with them on more than one occasion, and I said, you want to learn how to do this technique, I can teach you how to do this technique. This is a technique that will improve, and some of these devices will become commercially available. Why don't we work out a deal that's win-win for both sides? You bring your patient, I'll get you privileges at Barnes, and in those days it was a little easier to do that. They already had the state license, but to accomplish getting privilege, hospital credentialing quickly, now it takes a long time, but in those days it was a little easier. But anyway, I convinced them that this would be good, and it worked. It would work very good, and we've maintained this very close relationship. We did it with carotid stenting also. So I never felt that I was training my competition, which I was, but at the same time I felt that we developed a trust that then still the very difficult and complicated case, they send them to us, that for a while there they were actually being sent out of the city rather than send them downtown. So it's worked out.
It was a very innovative way to get a lot of cases done early on too, and be able to follow them up and learn about them.
Our volume grew tremendously, and
we were always very impressed, here at Northwestern, to see how the numbers were adding up down in St. Louis. Other things you were working on back then included, you were writing about a retroperitoneal approach to the aorta as an alternative.
When, as part of our kidney transplant experience, we were doing a reasonable number of living-related donors. And actually, Charlie had a protocol to induce tolerance with donor-specific blood transfusions. So the concept was to use the blood of the donor, give it to the recipient. If they didn't develop antibodies, that this would be a good kidney to use because they've already developed the tolerance to the tissue, in this case blood, from the recipient, from the donor to the recipient. So that we were doing a reasonable number. That program, it was an NIH-supported grant. That program had a lot of attractiveness for a lot of immunologists also because it tested the concept of tolerance, and a lot of research came out of that. But anyway, as part of the living-related donors, we were doing some of these kidneys. We were trying to maximize the length of the renal artery,
yes,
obviously, because that helps the transplant. And then it became evident to us how easy it was to see the aorta and the juxtarenal aorta. So it was really very simple to suggest, well,
you've been using the flank incisions, and then there was the aorta.
There was the aorta.
Yeah.
So why, if we can't get to the juxtarenal aorta and see it so well for doing a transplant, we can do it for aortic disease. So we set out to do, and for about 2 years, we did every aortic case, occlusive or aneurysmal, retroperitoneally.
Oh, I
and
see.
so developed all the tricks and learned all the caveats, and so that was very, very, allowed us to also train some of the other surgeons that would come in and wanted to know how come they were having trouble with the retroperitoneal, and we could do it claim to do it so easily, and we showed them some of the tricks that we learned, but by doing a lot of them, basically.
One of the interesting developments is that the carotid endarterectomy has remained quite popular despite stenting. What do you think about that? Are you surprised that we're still doing a lot of carotid endarterectomies?
Yeah, that's a very good question, and a question dear to my heart, because when I was in the leadership of the SBS, I was part of the debates and to some degree some of the battles that we had with the national coverage decision of CMS, with industry and some cardiology groups wanting to expand the decision to pay for all patients, symptomatic and asymptomatic, and we felt that it had not been tested adequately. So carotid disease and carotid endarterectomy is an interesting thing because it's probably the technique that has been challenged the most in the last 30 years, and it consistently wins out. Yeah. In every randomized trial, it doesn't matter who does it, how you do it, carotid endarterectomy continues to show that it's an excellent technique, and that the results are outstanding. So I'm not surprised because vascular surgeons or surgeons in general have been challenged about the efficacy of that procedure, and a lot of trials were set out to prove that the other techniques were as good, and that has not panned out. Every time carotid endarterectomy comes up as a very good, efficient way and safe way for stroke prevention. The next now is being challenged with best medical therapy, so that's going to be the next challenge. But so far we're doing pretty good with that.
Thinking more globally, I know that over the years you've been interested in the American College of Surgeons and setting up chapters in other countries. How did you get that idea? How did that all come to you?
Yeah, when I was part of I was part of the American College of Surgeons international scholarship system.
Oh, I see. Okay.
And ran some of the programs, chaired some of the programs, and helped set up some of the programs for the American College of Surgeons, especially toward the Latin American community. And I thought it was a brilliant idea to give opportunities to those young surgeons with a great potential in their country to be able to come and learn and be able to travel to 2 or 3 institutions in this country and take that back. And what caught my eye was that I saw people that were part of the American College of Surgeons chapters that had been recipient of those awards when they were younger, 15, 20, 25 years previously. So as I was involved with the leadership of the Society of Vascular Surgery, I didn't see why shouldn't that not be also duplicated in this in the SVS. We came into some luck. The American College of Surgeons have had significant donors to support that endeavor, the scholarships. I think they used to be $10,000 times 3. And we received an award that from the International Vascular Society, that and both Andy Whittemore and Dr. Greenfield gave that money that had been left by Dr. Haimovici to the SVS with the idea of promoting international participation in the Society of Vascular Surgery. So that's where this came out, this concept. We got support from Gore to support also at least one of the scholarships. And then I just thought, well, with some of my contacts in Latin America, that we should try that first, and we did. But interestingly, one of the first chapters that was formed was the Indian chapter, because there was an individual, a wonderful man, that actually by the Dr. Yao introduced to us, that he came to visit him here, and then he came to San Luis, and he started the Indian Society in India to form a chapter. And they were actually the first chapter. Concomitant to that, I was able to do the same thing with the Colombian Vascular Society, that I had been invited and showed them what some of the advantages. And I think it has grown. We've worked with Dr. Yao to form one in China, et cetera, et cetera. So I think it's a great way to internationalize the Society of Vascular Surgery and vascular surgery in general.
You've been interested in vascular centers in the past and talked about those. Where do we stand with those?
Yeah, I think that was a concept. As we were the vascular surgeons, we were trying to figure out our way of training our troops, our fellows, what would be the most efficient way of doing it. Cancer centers have been already established and shown to be a good way to give multidisciplinary care. Heart and vascular centers were, the concept was starting to be born, but it wasn't mature enough. So I think in some institution in which there was a very good working relationship with interventional radiology, we thought that that was worth a go. I think it was a good idea for that time. It ran into some problems related to the fact that, you know, there were two people, so therefore the economics of it was not going to be as easy to do unless you were part of a center that generated other funds that would cover the fact that you have two professionals, earning a reasonable living. But we were able to do it, and we actually for a while fused all the resources that vascular and interventional radiology generated. The chairman of radiology was thoughtful enough to, when he looked at the numbers, if we pulled the vascular lab out, the numbers were almost identical. So he said, don't be nitpicking, just put it all together, form a group all together. At the end of the year, you divide it. So we started that. We put some seed money, and the concept was that after we paid everything, whatever was left, then each chairman of each department would decide how much of the overage would go to this pot of money that was a conjoined venture. And that was working very good for 2 years. Then that person that was chairman of radiology became the administrator to the hospital, the CEO of the hospital, and a new chair came that didn't like that concept of pulling some of the interventional radiology money out to a separate venture. So everything fell have fell apart.
So you no longer do that?
So we have not been doing that probably for over 10 years now.
Oh, I see.
Yeah. So it's not, and some of the centers across the country ran into similar issues. There were other options of doing, okay, you do one case, I do one case, that we don't have to work together, but we'll split the money or whatever, or the revenues, etc. But I think overall, I think across the country, that has not been, in academic center, it has not been as successful as we thought initially it could be.
Another thing that you've spoken about a lot and know a lot about is the concept of training vascular surgeons now that we do so many cases endo and not as many open. And how do we train surgeons to be able to do open surgery?
Yeah, I think that's a concern that all of us that have been program directors have. 10 years ago, every fellow that we would finish, the question when they would go out to get a job, the question from the person that was interviewing them for a position, they would call me and ask me, can they do endo?
Yeah.
Now that question is never asked anymore.
Yeah.
It's a given. Right. Now the question is, can they do open surgery?
Can they do a good fem pop?
So it's changed tremendously, 360 degrees in terms of the ability, and we have that in mind. I just completed for cardiovascular journal. They asked me to write a chapter or a paper that the title of it was Open Aortic Aneurysm, a Lost Art. It is becoming a lost art. I think we have less and less, especially as we advance the endovascular techniques to fenestrated technology and branch technology. We find that there's less open aneurysms that are being done in our institution. The general surgery residents are not doing any anymore because there's few of them for vascular. So I have some thoughts on what we need to do, but it's going to require a lot of people in the leadership and training program directors to get together. I think we're in a transition phase. I think if we talk about the 0+5 a little later on, I'll give you some of the thoughts about what I potentially see happening. But I think that certain programs that have a lack of open surgery ought to consider establishing strong relationships with international programs that still maintain a significant number of cases that are done open, both in the aorta as well as the lower extremity. I think we're still doing, like you mentioned before, enough carotid endarterectomies. But it's usually for lower extremity and aortic surgery that this is becoming an issue. I don't have the magic answer to that problem, but I've given it a lot of thought, and I really think that we as a society and as program directors need to come together and start developing some strong strategies. Because although for endovascular there's good simulation technology, the simulation technology for open surgery is not the same. The three-dimensional component of required for open surgery is still not available for open surgery. The Europeans do some workshops and that are very popular, and we even have a box for an aorta, but it doesn't cut it in terms of training. So that's one of the problems that we have created but not resolved, and it'll be a challenge, and the program directors need to come up with some solutions.
What countries would the trainees go to?
Well, I think European countries in which, because they can go to South America or Spain, but language may become an issue. But I think some European countries, Scandinavian countries, some of the European countries, that there's still significant amount of open surgery where English is still a spoken language, even by the population, routine population. That the common population, that I think it may provide some opportunities. Belgium is one country that comes to mind. The Netherlands is another country where a lot of people speak English.
Mm-hmm. Do you think the 0+5 is a good idea overall? The training program where people come straight out of medical school?
That's a very complicated question. The answer is I thought it was not a very good idea initially. Now I'm completely convinced that it's the only way to go.
Okay.
And the reason for that is that we're training different types of residents. I think in an era of our restrictions that I don't see where that's going to go away, we need to start coning down training to in everything, in transplantation, in hepatobiliary, in colorectal, you name it. I think that the hours are not enough, and you do not have the luxury now of spending a lot of hours doing things that are not focused toward the training in that field that you selected. And therefore, that's why I think 0+5 is going to be the way to go. I think we're starting to see some changes even in general surgery. At least there's some pilot projects to short track people within general surgery to the areas that they're interested in. Some people are calling it flexible programs, etc. It's a new idea that's becoming more popular. But I really think that there's no way that we can train people in the same way that we were able to train people in multiple areas, in an era in which technology advances so quickly, and have them do things that have nothing to do with what they're going to be doing. And 2 years may not cut it. And that's why, and we're not in an environment that we can just keep adding years to vascular training. So I think that now we're going to go through growing pains, but I think the 0+5 allows 3 full years of vascular training. I
So
think
you get an extra year of training, really, out of the...
an extra year of vascular training.
Of vascular training,
That is
yes.
correct, yeah. And during the 2 years of so-called general surgery training, they still get some general surgery. So we have a 0+5 in our program, and it is amazing to us as we started interviewing how many good applicants we're getting that are AOA, top of their class. So these kids are very, very bright, and they know what they want, and you still have to have the flexibility for those that are going to do the 5+2. But I really think that there's plenty of these students that now that creates a challenge for us to get them interested at an early phase during their medical school. So we have to be very active in programs to make sure that we give them an opportunity to see what vascular surgeons do.
Do you have some general advice for young people, medical students that would want to go into vascular?
Yeah,
as a career?
I think that they need to shadow surgeons, vascular surgeons during their medical school years. Realize that we're just as humans as everybody else, and that it can be it's a fun specialty, and it's probably the only specialty that's around that gives you medical knowledge, catheter-based knowledge, and open surgical knowledge. So it is a unique specialty in that respect, and I think that they need to shadow and work with surgeons, see what they do, and they will find that it's a wonderful specialty.
Tell us a little bit about your hobbies and sports interests and so forth.
Well, I have a lot of hobbies. I like to read. I used to be a coin and stamp collector, but realized that it was hard to keep up with that, so I sort of put that aside and passed it on to some of my kids. I love the game of golf. I played a lot of golf since I had some orthopedic problems. I'm not playing that much golf anymore, but I still ride with my friends and enjoy the game, and probably shooting the best scores that I've ever shot, not hitting the ball, because I can criticize them. But yeah, I'm a avid baseball fan, and I've always come from a country where baseball is big. Have blood from the Dominican Republic and Puerto Rico, two big
Pretty
countries
serious baseball
for
countries.
baseball countries, so where it's played all year around. So I follow baseball very closely, and I enjoy seeing it and following it at all levels. So, and I like to fish. I don't get out to fish as much, but now that I have grandchildren that are getting old enough, so I'm getting back in it to taking them out fishing, and that's a lot of fun. Yeah.
You've always been pretty interested in cigar smoking and cigars in general.
Yes, that's an interesting story how that came about. That came about from my relationship to the Dominican Republic. As you know, my father was from the Dominican Republic. I actually have a bigger family in the Dominican Republic than in Puerto Rico. So I visit there frequently, and I have family that are big cigar aficionados.
Mm-hmm.
And was able to go to some of the plantations there and meet some of the cigar owners, etc. And was always curious why Cuban cigars were quote unquote the best. So I decided to become knowledgeable on Cuban cigars.
Mm-hmm.
And I've read a lot. I've been to Cuba. I'm not a heavy smoker of cigars. I think that they're bad, just like cigarettes are. But an occasional cigar is very, very good, and I enjoy. And I have become I can tell you what a cigar is. I mean, like just like wine tasters can.
Uh-huh.
I've developed that skill
Uh-huh.
in cigars. I'm losing it now because I smoke only once every 3 or 4 months a cigar. But when I used to smoke a little bit more, I could tell you what brand it was.
Oh yeah.
So, and I can tell you when it's a good cigar and a bad cigar. So, so I developed a good taste for that.
Oh, yeah.
I still enjoy a good Cuban cigar.
Yeah, that's fun. Tell us a bit about your family.
Well, I've got a wonderful family. I've been married for 48 years to Kathy. That I met in San Luis, and that's like I told you before, that when you come from a foreign country and you end up in a specific area, follow the track, because there's a woman there somewhere in that decision making. So we have 4 children, 2 girls and 2 boys. My oldest 2 are girls. They're both nurses. One is a nurse practitioner. The other one still wants to do nurse practitioner. The nurse has worked for a long time at the San Luis Children's Hospital as a nurse in the NICU, and loves that. The other one is a nurse practitioner that works with the genetic diseases, pediatric genetic diseases. My 3rd son, Greg Jr., he is a physician, did internal medicine, and didn't know what he wanted to do. Was unsure whether he wanted to do cardiology or gastroenterology. Definitely didn't want to follow my steps because we have the same name. He said that'd be terrible. So while his wife was doing a fellowship in orthopedic veterinary medicine, he did a master's degree in medical informatics. And I thought it was the silliest thing in the world, but just to show you, dads are usually wrong, kids are usually right. So he works 2 days a week as an internist and 3 days a week making a lot of money setting up electronic medical records, something that we doctors hate. But he knows the contents. He's always been a computer person. Plus he knows the medical content. So he works for a company that's based in Colorado, but he lives in Portland, Oregon, but all of that is done electronically. And he has, and then my youngest son that lives in San Luis is 38 years old, so I've got older kids, owns a toy store and has been very successful with that. We have 8 grandchildren. 5 of them live in San Luis, and we're very close to them. Obviously,
That's
see
nice.
them every day. And the other 3 in Portland, we don't see them as frequently, but we get together at least 2 or 3 times a year with them.
Is there anything that you'd like to reflect on related to when you were president of the SVS or the national medical agenda?
Yeah, well, I think the Society of Vascular Surgery, I think, is a unique institution. I happen to be in the leadership of it at two interesting moments of the society, but all societies have multiple interesting moments. One of them was the duplication of efforts, and it became evident that why did we need two societies?
Right.
And I think under the leadership of Jack Cronowet and others, the society came together. That required a tremendous amount of work, but it was a great, I learned a lot.
And decisiveness, too.
And decisiveness. There was a
A
lot of
decision had to
pushback.
be made, yes.
There were a lot of pushback. We made a lot of enemies that then became friends, eventually. Friends that became enemies that became friends. But I think it was the right decision to make, to have one society. And it has paid off because and at a time where there's so many challenges to medicine and so many changes that occur, to have one voice really made a big difference. The other thing that was at that time very difficult, but I think the clever heads prevailed, which was the issue about whether we should become a different board. And I think that the decision was the right decision not to do that. I think that, and actually the American College of Surgeons was also, has been a support structure for the SVS to maintain its cohesiveness. I think the American board, but at the same time, it was this push to become independent that really led to a lot of changes that have helped vascular surgery. We would have never had a 0+5. And furthermore, I think it's a lot of those changes that was brought up by vascular surgery that is changing education in surgery. I think that is making them realize that the old paradigm of training people like Halsted in the Halstedian way is not the way of the future. So I think a lot of that was the vascular surgery trying to find its independence in its way of establishing a voice as a separate specialty that made some of those changes happen. So I think it was fun. I think the SVS continues to grow and continues to be an important voice in medicine and a respected voice in medicine. I can tell you from my many years of working with the FDA and CMS that the SVS is respected as a society.
You've always been interested in outcomes and quality improvement. Where are we going with that nationally, do you think?
Oh, I think it's here, and I think it's here to stay. I think the public demands it. I think the insurance companies demands it. But I think it's like I said, the public demands it. I think that's what's right for the patients to have. We know that bad medicine is expensive. Good medicine is not only satisfying and the patient does well, but it saves money. And we know that we have to figure out ways of having an efficient system of healthcare that has good outcomes. And so I think we're in that road. Mm-hmm. I think the SVS, the American College of Surgeons, I think have been leaders also in that area of trying to measure outcomes and make outcomes make a difference. And I think the insurance companies, that's another area that I think we're very well respected because of the leadership of the SVS and the surgeons, the American College of Surgeons, in that area.
Is there anything else you'd like to bring up that you'd like to reflect on?
No, I think
We've covered a lot of ground.
We've covered a lot of ground. I've had a great career in this country. This country opened their arms to me, although I was born an American citizen, but came from a slightly different background. But again, it just speaks for the greatness of this country, that diversity, and if you are willing to work hard, you get ahead, and it gives you everything they have to allow you to succeed and to help make things better for everybody. So it's been fun.
Well, Greg, I really enjoyed it. Thank you for coming and talking with us.
Appreciate it.